All right, so this is a really exciting piece to me because it is my home, it's where I work, and it's exciting when your family actually believes in what you do. And so I'm gonna give you a little overview of what has brought this particular group here. And many of us, several of us at ETSU, and even some of the others who will speak later, are affiliated with ETSU in other ways. But several of us have been working independently over the last several years. This past spring, again, I mentioned Wally Dixon, our chair, brought us together, I guess, as sort of like he knew all of these things that were going on, and Michelle Moser, and I should have had you up here too. Hindsight. Doing things already and addressing and mitigating ACEs. And so we brought this group together and began brainstorming where I do something sort of big. Wally is good at just saying, oh, let's just do the whole shebang. And so it was his idea to say, well, let's just be the first trauma-informed university. And I'm sitting there going, oh, wow, yeah, this is good, because I've been out in the community. I haven't really tackled my own place of employment. And so the group began working. We worked over the summer. We met over the summer, and if you are not a faculty member, you don't know what that means, but that means a lot. We don't have to be there, but we were there. And so our goal that we aspire to is obviously that any of us aspire to is preventing ACEs. We don't want ACEs to happen, then we don't have to mitigate effects, we don't have to address trauma later, we don't have to offset that. But we know that our campus is covered in people who have already experienced their ACEs, or even trauma in adults. And so not just the students, but the faculty, the staff, the administrators, whoever, they've already experienced that. And so we, with this sort of collective knowledge, need to do something about that. And so we know we've started gradually collecting some data on our own students. We know that in Tennessee, if you want to count ACEs, and we don't always want to count them, but it gives us a metric, that 1 in 5 adults have experienced 3 or more ACEs. We know on the campus, 1 in 4. So already we're higher, and that's people in college. Think of the people that didn't make it to college, you know. So we know in Northeast Tennessee it's a high number, but we do know that there are things. That's what this all is about. That there are things we can do that can help offset that. And so some steps that we're already talking about doing. First is changing our institutional culture so that our faculty are trauma responsive, that they understand, they're aware, but also responsive. And we just love to throw in little stories on each other that nobody knows that we don't know they're going to say. But this morning, before I came, this is a new one, I got an email from a student that said, and so I get to practice this already, an email from a student that said, I don't even know if it's okay to email your professors about something like this, but last night my stepfather beat my mother, she's in the hospital, I think I'm going to miss class. And it was like, that is fine. Yes, it is perfectly appropriate. Please let us know. Keep us in the loop. Let us know what we can do. Because there are times that college really, really takes a back burner to life. And so, I want to practice that, but also give other faculty the tools to do that. And so that's just one of those situations that comes up over and over and over, and the more students feel safe, the more that can occur. A second step, we would like to help our frontline, and we pick on financial aid, that's not really trauma-informed, is it? But so that the financial aid person, or the person who says the class is full, or whoever it is that students in a tight need things from, also greet you with the welcome, not the 40-page form, and don't put up the "we're closed" sign, but "so sorry, can you come back in the morning?" Something that warms the relationship with whoever it is that they come in contact with first. But even beyond that, because go big or go home, we want our students to leave, all of our students, to leave with an understanding of the impact of adverse childhood experiences, and also this, this trauma-informed lens to look at the world through. And so we want to embed it in general education coursework so that any of our students that we turn out onto the streets already have this information that a lot of us have just gotten, you know, way into our careers and so forth. And so that's going to have an impact on the community, that if it's someone in a business who's hiring, or if it's a medical professional, or if it's a teacher, whoever. We've already started training some of the no stealing thunder, teachers and so forth. But they'll tell you all kinds of good things that are going on. And so we want to send out this army of ETSU graduates and non-graduates, people who have interfaced with ETSU. We want them to have this information in their toolkit. And so we have the manpower, and we have the understanding and the knowledge and the motivation and the champions, I think, to become actually the first trauma-informed entire university anywhere. How cool is that? And so we want you to follow our progress, but we also, because we haven't done that yet, the thing that motivated us to even go down this path is some of the work that some of the other faculty members have already begun. And there's several, I didn't even tell you the name. We're calling ourselves the Brain Trust. I wrote it down here. Is there? Oh, good. It's got the name up there. I can cheat. Oh, yeah. I did that, didn't I? Oh, that was you. Okay, so yes. Building resilience through ACEs-informed networking. But we figure if it's an academic institution, brain is really important. And so this is the people that have been meeting all summer to make this happen. And if you would, raise your hands out there. Some of you are up here, but several of you are all over the audience. Yeah. Yay! So there are a bunch of us. And so our next person will be Julia Bernard. These people have all been already doing this work. And so we're beginning the cheerleading now of things that are already going on in the area that started forming the structure of this group. Julia? Oh, there you go.
I'm short, so I gotta bring this down. So I'm Julia Bernard, and I am the interim chair for the Department of Counseling and Human Services. And you'll hear a little bit about our research and some of the other things that I'm involved in a little bit later on. But I wanted to talk to you today about my students. And so when I first helped with the first SAMHSA presentation here at ETSU that Becky and Andi had organized, I knew I was hooked. They got me. And I'm in her cell phone, and she calls me when she needs something. Trauma-informed care is something that we try to teach to our students anyway. We try to teach them on a daily basis compassion and empathy. We try to teach them meeting people where they are. So trauma-informed care just made so much sense to me, to our program. So I attended Becky and Andi's Train the Trainer seminar, and I began teaching trauma-informed care in my counseling theory and practice course. And I offered it also to my master's advanced developmental psychology course. I could not have imagined the connection that these students would make to this information. My students, by the very nature of what they are studying, are eager to help in any way they can. They are nurturers. When they leave our programs, they are generally that first line of defense in those mental health agencies, in the nonprofits, in the community agencies. They are caseworkers, there are counselors, there are facilitators, there are family advocates, there are home visitors, there are DCS workers. I can vividly recall sharing the training for the first time in this undergraduate course. The students are about in their junior year when they get to counseling theory and practice. So they're getting ready to do some practicum and internships. A lot of them are doing their practicum concurrently with the class. And we did the rundown of research and theory and things that are important in our particular field. But then I teach them trauma-informed care. And I show them the video removed. And if you've not ever seen the video on YouTube, you can find it. I believe it's a 12 video series.
12 minutes.
So, I showed them a very short 12-minute clip, and they watched this child go from an abusive, violent home to the foster care system with not so good foster parents, to a loving foster care home. And they get to see her reactions along the way, and they get to make that connection with her past. They get to see why she's acting the way she's acting. So it gives them their aha moment. You see it in their faces. You see it in their expressions. So in our program, the students in undergraduate human services do 350 hours of community service before they graduate. And so immediately in the debriefing after that movie, they start talking about the children they've seen, what they've seen in their practicums, what they've seen in their volunteer service. And they make that connection. So they start to think about what happened to those children before they saw them. It's a powerful moment in their training, and more important, they'll leave my classroom a little bit more patient, a little bit more understanding, and a little bit more willing to hear the stories of the children that they work with. So I also share with them the story that Joan Gillespie and Brian Sims shared with us at that first presentation about the corrections officers and how painting those girls' rooms, their cells, made a difference in how they went to sleep. So I won't repeat the story again, but obviously horrible things happened to them at night, and changing just a little aspect of how that nighttime routine went made a difference. Did it remove all the girls' problems? No. Did it change the girls' past? No. But it was a more compassionate way to approach the problem. So that's what teaching trauma-informed care is about. Students get the understanding that brain chemistry changes toxic stress, and it accumulates. But with the presence of safety and trustworthiness and transparency and peer support and collaboration and mutuality and empowerment and voice, and giving them a little bit of choice, taking into consideration their cultural or historic backgrounds, their gender issues, all of these things make it a little bit better. There's a capacity to repair some of the damage that happened across their development. They can make a difference. They can make a difference. You can make a difference in these kids' lives. So healing starts when a person's personal experience is heard and validated, and that's what I'm hoping to give all of my students. It also causes a little bit of healing to happen within them. So we have these talks, we talk about resilience, we talk about healing, and they also have that understanding that ACEs is not destiny. They have made it to college. They are now going out there and helping other people. So even though they've had their own past and their own ACEs history, they can make a difference in the world going forward. So I'm grateful to Becky and Andi for training me and giving me the opportunity to do this with my students. I'm grateful because it's made me a better professor. And I'm honored to be part of the system of care in Johnson City and the Brain Trust and the research projects for building stronger brains. It's been an honor, and again, it has helped shape me into the professor that I am. Thank you.
I'm Judy McCook, and I teach in the College of Nursing, and I want to make sure everybody hears that it takes a village to do this. And without the support of these fabulous people, I wouldn't be getting to do the most fun thing I've ever done in nursing. I've been a nurse, a women's health nurse. I've been a nurse for 40 years. I've been teaching almost all of that at 5 different universities. And I now think I am doing my very most important work. And that's even after working with infertile couples and all kinds of folks with health conditions. So I want to start by telling you what I was able to do because I was coordinating the introductory communications course. We have a module on introducing ACEs and trauma-informed care. And they get this in their communications course. This started back in the spring, and they at least get introduced. You know, they get to understand the basis and how it impacts health. And that's one of the things that I really hit home with them. So we're educating about 300 students a year in a variety of different ways. You call us up, you've got 1 hour, we're there. You got 2 hours to spare, hey, we're there. We're doing a 3-hour session. You know, we're very flexible. If you're interested in learning about this, you just give us a call. So that's what's happening in communications. We're expanding it to the interprofessional communications course that we teach on the VA campus. Julia Dodd is helping me with that. We teach communications, and I've done this for about 15 years with medicine, pharmacy, and nursing students take communications course together. It's truly an interprofessional course, and it's time that we make sure everybody is trauma informed in that. Okay, so that kind of covers nursing. So now the next step is I'm going to make sure I read this. The Tennessee Department of Children's Services, Building Stronger Brains, generously helped fund us this summer. Megan Quinn headed that project. We got funded. We would have done it anyway free, just saying. But you know, okay. But anyway, we were delighted that we could share with our leaders that we could buy out a moment of our time to get to do this. So we're training, we actually already trained the faculty. So we've trained the faculty on trauma-informed care and ACEs, and then we are going to teach the students, 24 classes, is it? 24 classes, 400 pre-health students. So these are guys that are thinking about medicine, they're thinking about pharmacy, med tech, nursing. Thank you. So we've got to, so we get to go in, and these are people who are going to impact people's lives for the rest of their careers. In addition to this, I love teaching undergrad students because they are going to be future parents, grandparents. Some of them are current parents and grandparents, but it has long-term implications. Let's see. Oh, and last week, on my birthday, I might add, we had permission from our IRB to distribute a survey on ACEs and trauma, well, ACEs and resilience. We are trying to see if career choice is impacted. In other words, do people with high ACEs scores go into helping professions or health professions? So we're going to take a look at that. The data is so preliminary, like it's not even clean, but we just had a look at it yesterday. And we have 500 surveys back. And again, is this prelim data? Not, you know, I just can't say enough about what it's not. But it looks like 1 in 5 students that reported have an ACEs score of 4 or higher. And 4 is magic because that impacts health. That's when we start seeing, you know, the negative impact on health. Okay, so let me tell you, I am also a trauma-informed nurse. I'm a sexual assault nurse examiner, and we see patients in the most vulnerable time of their lives, and a trauma-informed nurse is going to help begin that healing process. So that's all I have to say about that.
So my name is Kim Hale, and I serve as an Associate Dean in the College of Education. And if you were to ask my faculty, and Julie is one of them, they would tell you that it all started with us. That in 1911, East Tennessee State Normal School was established across the street for teachers, right? We are very, very proud of that. And we've been long dedicated to learning and setting high expectations and demonstrating profound respect for others and having compassion and advocating. We know we've made an impact. And as Dr. Noland always tells an audience, and I continue to tell my students, and I continue to tell my colleagues and my faculty, we are here to improve the lives of the people in this region, and that's our purpose. How many of you in here are K-12 educators? Do we have some folks? Yay, welcome. You are gonna so relate to the next minute of my life that I'm going to. If you walk out of here to any school system in this region, you will find a large number of ETSU College of Ed graduates. We have a very heavy footprint here. We provide education to students who will be teachers, counselors, instructional leaders, coaches, principals, superintendents. Sometimes I know it's probably overwhelming to Dr. Noland when he goes to speak to a group of teachers on the first day and he says, how many of you are ETSU graduates? And 98% of the room stands up. We every year have 150 or more teacher candidates who graduate from our university. Like other colleges of education, our enrollment has dropped recently. Being a teacher is hard. Lots of times there's negativity and blame, and we've seen that across our country. It's bouncing back, so I think this year we will have about 175 students graduating in May. They have to do a lot of field hours out in the world. Starting sophomore year, they are in a classroom, they are engaged, and by their senior year, it is 3 semesters in the classroom, and by the time they finish, they have about 800 hours of being engaged in a classroom. We really want them to be ready to teach on day 1. And the State Department of Education in Tennessee has been fabulous to help support the quality of what we offer to teacher candidates and all instructional leaders in our colleges of education. So sometime last fall, I went to a training. I'm a recovering school psychologist, is what Brian Cinnamon told me yesterday in Kingsport. I spent 12 years of my life in public school as a school psychologist, and there was this trauma-informed care training, and I decided I should take time out and go. And it was really a bit earth-shattering because you know what? I've been here for 11 years and I had forgotten, and it was something that I vowed would not happen to me when I walked into the ivory tower, and it did. So I went back to my faculty, and in all of our busyness, striving for test scores, striving for high ed TPAs, rewriting our curriculum for literacy standards, writing grants to improve math and science, making sure that we are on the cutting edge of pedagogy and research. Does this sound familiar to anybody? We live and die by test scores. I know you've been doing that in K-12 for a long time. Colleges of education in this country are doing the same. We have to be able to show quality outcome. And so we focus a lot on those scores and percentages and completion and GPAs and dispositions, and we've embraced a new accreditation body that's very rigorous, and it's a bit overwhelming. So when I came back from trauma-informed care, we all took a breath, and we had to remember the reason that we're really here is to help children learn. So we had a training last spring, and as Becky mentioned, many of the students afterwards had so much to say. We had about a half of the students who were graduating attend, and I had lots of comments I could have shared, but this was the one that I wanted you to see, and I'll read it to you, because I wanted you to see how it's changed this young lady's perspective on children. We have a lot more to do. We'll embrace more training, and especially helping our faculty to be better in teaching about the whole child and not just the cognitive academic part. But this young lady said, my mentor was beyond frustrated, and after helping 3 students, she asked if I could help one more because she had explained it 3 times and one little girl still did not understand. Does this sound familiar? And as embarrassing as this sounds, I was a little bit lost when I first read the directions on the math sheet. However, after realizing we had to use tiles and we had to write an equation, I was able to understand what was being asked. And as I was helping the different students, I realized that my tone has changed since being a part of the trauma care presentation. I do not think I was mean or harsh in any way. but I did become impatient when children did not follow directions or understand the task. I now look at children in a different way, and this really helps me keep my cool and teach the children with a gentle tone. In other words, trauma-informed care has helped my students remember to focus on the children, not just on the content and the success and the outcome of the scores. So thank you, Becky and Andy, for that.
Good afternoon. My name is Brian Noland, and I have the honor to serve as president of East Tennessee State University. I also have the honor to work with individuals such as those we've heard from today and those in the audience who truly are committed to the mission of this institution, a mission that in many respects is forgotten in states. We live in Northeast Tennessee. For all intents and purposes, for many in the state of Tennessee, the state ends in Knoxville. Everything north and east is quite often forgotten. As a result, we serve as the land-grant institution for this region, the institution focused on making a difference. And several years ago, we were going through a strategic planning process that was chaired by Dr. Wally Dixon, who's here today. And in that strategic plan, we talked about all the things that institutions talk about: growing enrollment, improving retention, increasing our outcomes, graduating more students. But there was a point that Dr. Dixon kept coming back to, which was, how do we as an institution embody our values, which say that people come first and they're treated with dignity and respect? For Dr. Dixon, it was, how do we embody a culture of nice, which is a lot easier to wrap your brains around than people come first and they're treated with dignity and respect for a land-grant institution and all the lexicon that's included within higher education. But as we started to think through what that means, what I was struck by was the power of our institution to impact this region. If you were to draw a 30-mile circle around our present location, 80% of the people with baccalaureate degrees received that degree from ETSU. And if you expand that out 150 miles, 75% of all the healthcare practitioners in that radius graduated from here. We live in a region that's undereducated, wrought with poverty, struggling with an opioid addiction that is beyond description in terms of an epidemic, and all of the things that regions shouldn't be good at, we rank at the top from the wrong perspective. So obesity, diabetes, prescription drug abuse, etc., we rank at the top of the state in those categories where we'd like to be ranked elsewhere. So what does all this mean? It means that we as a university really have the ability, if we focus, to impact the lives of our students who are ultimately going to go out into the community and impact the lives of this region. So as we started to look at what we as an institution could do, in some respects we began with that charge that Wally put in front of us, a culture of nice. This is the first 2 weeks of the academic year. The academic year began on Monday of last week. Thankfully, we made it through this week without having to close the campus down because of the things that we experienced last Monday. But as we began the campus semester, there was a point in time in which we removed students from the profile of the university for non-payment. That was heretofore known as the purge. So if you're a first-generation college student, 40% of our students are first-generation. If you rely upon financial aid to cover the cost, more than 70% of our students rely upon financial aid to cover the cost. And if everything's not in place right before the semester starts, you're purged, which means all of your courses are dropped, which means you then have to roll into offices on Monday and rebuild your entire semester worth of coursework. And then you still have to try to remedy the issues that put you in a position of non-payment. That word purge in and of itself is a triggering phrase. And the means through which we work with students who have been adversely impacted is something that many of the faculty on campus and staff in particular do not have the skills and resource to work through. And that's what we're looking to change. I've got to admit I was new to this field, but through the work of the Brain Trust, through the work of many of the faculty that are here, they've imparted on me the importance of this work. Not only because it's the right thing to do, because if we're going to hit the metrics that are entailed within the strategic plan, if we're going to hit Governor Haslund's Drive to 55 initiatives, if we're going to meet our mission, we have to look at how we as an institution are structured and operate differently, because our students are different. Our students are bringing with them points of history from their childhood that impact how they work through issues on campus. Several years ago, there was a young man who came into my office, first generation college student. His mother was unemployed, never met his father, and he had $250 worth of parking tickets that if he didn't find a way to pay, he wasn't going to come back in the spring. And that individual ultimately graduated, now working on his master's degree, but he's one of thousands of students at our institution who are really struggling to work through the life challenges that life presents to them. And the work that we're doing in our attempt to become a trauma-informed institution hopefully will ensure that those students are able to be provided with the support to navigate the processes of our university. But it's more than that. We, in conjunction with our partners at Ballot Health, several years ago, opened a center that treats individuals who are suffering from the opioid epidemic. The location in which we placed the facility was not popular. I'm still, in many respects, not altogether the most popular person when I go to my son's basketball games in Gray. But ultimately, we can no longer stick our heads in the sand as a region and say the opioid epidemic impacts someone else. It impacts all of us. It takes all of us collectively as a region to bring together cross-disciplinary interventions to ensure that we're able to impact the quality of lives of the people who call this region home. And I'm proud of the work of the individuals who call our Center for Prescription Drug Abuse Prevention and Treatment home. But I'm also proud of the work of individuals who comprise the Brain Trust. You've heard a little bit about them, and I know I'm running low on time. I kept watching everyone else get the cue cards. I'm no different than anyone else. I don't have an assigned parking spot. I don't have time, so I deserve the same hook as anyone else. But I want to talk a little bit about what we're going to do as an institution. In 2 weeks, we're going to bring to our Board of Trustees background information that's been led by the Brain Trust, outlining for our Board of Trustees the outstanding work that our faculty is engaged in, the volunteer work that our students are doing, and providing a lens for the board to then provide a vision for this to move forward as a strategic initiative of the institution. But once again, it's not a strategic initiative of this institution. Ultimately, it's a strategic initiative of this region. On 2 separate occasions over the course of the summer, I had the chance to be a part of conversations at the Niswonger Foundation in Greenville, both of which from beginning to end centered on trauma-informed care and ACEs. This is something that's critically important to our board, it's critically important to our faculty, but ultimately, it's critically important to the people that we ultimately help to serve, and that's our students. Far too many of our students will graduate from college with debt. Far too many of our students will not graduate from college at all. Not because of academic challenges, not because of financial challenges, but just simply because life got in the way. Before coming over here today, there was an international student who was in my office in tears because they didn't have the resources to pay for insurance, and if they didn't have insurance, they couldn't enroll in the university. So we are going to find a way to pay for that person's insurance, because that's what we're supposed to do. We're here to serve this region. It's a region that the state of Tennessee quite often forgets, and the only way we're going to address the population health challenges that face this region is if we all come together as a region and tackle it head on. And I'm proud to be a part of that effort. This is a wonderful university. It's a university comprised of wonderful people, and great, the ballot sign's still up behind me, because that's the last piece of this puzzle. We cannot do this on our own. We have to do this in conjunction with the healthcare system. We have to do this in conjunction with the educational sector, K-12. We have to do it in conjunction with our partners in public safety. This is a region as a whole. See, I'm getting a hook. But I mentioned earlier yesterday a conversation that I had with the CEO of the healthcare system. We talked at length about children in the NICU and how we as a university can provide better coverage and care, because if today's anything like yesterday, 50% of the children in Niswonger are suffering from NAS. But once those students transition and become students in K-12 sectors, et cetera, how are we prepared to work with those individuals? So you're going to see us, in conjunction with the healthcare system, funding initiatives that support literacy, that support community engagement, that support improving population health for the region. So as you watch what happens here, it's not just ETSU. No one faculty, no one institution, no one individual can do this alone. It takes the region, and what's going to help us move in more ways than I can begin to describe is a partnership with Ballot. So thank you for giving me a chance to talk a little bit about the university. I had 16 pages worth of notes. There was no way I could have read through them. Thank you for giving me the hook, and thank you all for being here today.
It was great. I want to tag in to what he said. I think bottom line is we're all sort of redefining who we are as institutions and as organizations. because we need to, number one, we need to redefine who we are because the needs and the opportunities within the community are different than they've been before. So we're working on that as well and redefining who we are as a children's hospital, who we are as a health system. And we are on the road to becoming a trauma-informed hospital, and that will then hopefully bleed on into where we are as a healthcare organization and what we're doing within this region as far as it relates to health. So, oh. There we go. All right. So, a lot of things that you've already heard today. I mean, obviously we have opioid crisis. We have increasing numbers of neonatal abstinence syndrome in our units. And we've got evidence of toxic stress. So the best thing I can do is probably just to share a story of my aha moment that we've got to redefine ourselves as a healthcare facility. We've got to redefine what we do. And I had been to Becky's training, Dr. Clements' training, and I had heard about it and absolutely was engaged and bought into it and understood it. It made perfect sense. But about a year ago, I was in my office on an afternoon and I was on a phone call and my cell phone started literally lighting up, and I started getting text messages, phone calls, and then my assistant came over to my office and she said, "They need you down on the floor." And we had had a threat within the building, and that's obviously something you never want to have to do. But, you know, we have a lot of protocols and things that we put in place in response to that. So obviously we went on lockdown as a facility, and we went through all the stuff that we do to try to, you know, mitigate that threat and mitigate that risk. And law enforcement came, our director of safety and security for the system came, and we needed to go talk to this mother who had reported this stress and try to figure out what was going on. Her son was in the hospital, he was 2 years old, and we walk into the room, and I had heard bits and pieces about different things and what we were dealing with, and I walk into the room, and a mom is sitting in one of our recliners. She's got her 2-year-old in her lap, and she starts to tell me this story. The dad's girlfriend had called, and she's on her way to the facility. She's going to shoot her, and she's also going to shoot the 2-year-old and anyone who gets in her way. And I'm sitting there listening to this horrific story that she's just relaying to me like I just asked her what she had for lunch. Really not a lot of emotion, not a lot of alarm. I mean, and I'm, you know, I had the training, so I'm trying to keep, you know, not react and validate what she's saying to me, but I wanted to go, you know, I mean, but she's telling me this story again with, like it was an everyday occurrence, because guess what? It was. Because then she starts telling me what happened the day before and who came to their house and kicked their door in and who vandalized their car. And so I sort of then stopped listening to her, and I focused more on her facial expressions and how she was responding to that. And again, this was just everyday life. And then I started looking at this 2-year-old who was sitting in her lap, and I thought, that is just toxic stress to the nth degree. This is his life. This is what he's growing up in. There is no guarantee of safety. There is no guarantee of tomorrow. There is no guarantee that we're going to make it out of this hospital alive because someone's coming to try to harm us. And that's when I realized, because I can tell you to this day, I have no idea what his admitting diagnosis was. I don't know what quality metrics we met. I'm not sure if they even got a patient satisfaction survey. I mean, all of that stuff just went right out the window because it just all became irrelevant at that point. And so that's why I say we're trying to redefine who we are, because things that we have been judged by, as we just heard, test scores and numbers and all of the metrics that we're using to judge what we're doing really are irrelevant when you think about the human life component and what this boils down to. we really needed to do things differently for this family. We really needed to try to set them up in the community for success and get them in a different place. And how can we as a hospital affect that? And we have great opportunity to do that. We have great opportunity to affect people's lives positively. And I've said it and I'll continue to say it. If we only treat the medical conditions that people come in with, then we've really done them a disservice. We really have to do more than just treat them medically, because like I said, I feel certain he got great care and he went home, but I have no idea outside of that, you know, what he needed as far as his medical care goes. That was really secondary to what was going on in their life and the social dynamics. And unfortunately, those stories are not uncommon. They're really not uncommon. I mean, we just heard one about ETSU last week. It's the nature of the world we live with, and how do we then work to combat that? So that really is why we're on this journey to become a trauma-informed hospital, because we really want to meet people where they are and try to do more than just serve their basic medical needs. So I'll skip through a lot of these, but I'll tell you some of the things that we're working on. We have, again, attended the ACEs training. We've made a commitment, like I said, to becoming a trauma-informed facility. We're really working on offering some grand rounds and doing some participation. You're going to hear from the people who are on the team, really at the ground level, doing a lot of the work. We have developed a committee that is working to look at all of our practices. How can we incorporate our child life specialists, which are great resources within hospitals who are trained, they're individuals who are trained to deal with cognitive and developmental needs of children. And so they really are the front lines to do those assessments and figure out, you know, what's going on in the life of this child and what's going on in the dynamics of this family. So we're working to train those staff members so that they do a different type of assessment. It really is a different kind of assessment. We're really good at listening to, you know, heart and lungs and taking vital signs and doing all those things, but we have to assess the family and the children differently to figure out what other needs and resources they have. So we've enlisted Becky Haas from the Community Crimes Prevention. She's very much a part of the work that we're doing and what we're doing as a healthcare organization. So one thing, and I'll skip to what we just did recently, we did trauma-informed training at a regional conference that we sponsored that included 175 school nurses. So Dr. McCook said it takes a village, and it sure does. I mean, it takes everybody hitting this from all angles and all aspects. I mean, how can we hit it wherever we can? We have access to kids in the hospital, but we also have relationships with schools. So how can we partner with schools? And that's one thing that we are absolutely doing moving forward. Unfortunately, we have a very, very large population of students that school is a trigger for a mental crisis in their life. I love technology, but my wrist is vibrating like crazy because, unfortunately, even today in our hospital, we are seeing patients continually to come in who need mental health services. I'm getting the updates. We're now holding 4 patients in our ED who've been committed that need psychiatric care. This is real. I mean, this is what we do every single day, and we have to back it up. We have to back it up and figure out the whys, and we have to figure out how to really make a difference and an impact in the lives of these children, because these are the future. These children are the future that we're looking at, so we have to be able to impact their lives. I'm now going to flip it up. Did I do a good job? I'm going to flip it over now to Dr. Karen Schetzina. She's a professor at East Tennessee State University and works in the pediatric department. She also works very closely with me on the facility side in our Children's Resource Center at Niswonger Children's Hospital.
Okay, good afternoon, everyone. And I'm really happy to be here. So, as Lisa said, I'm a professor at ETSU. I'm a general pediatrician at ETSU and Niswonger Children's Hospital. I've been here for 15 years. And for the first half of my time here, I practiced almost exclusively as a pediatric hospitalist. So that meant that I just stayed in the hospital and took care of children and infants and adolescents who were admitted to the inpatient unit. During those years, I witnessed a lot of trauma. So some of these cases were very obvious. Children who had been physically or sexually abused or experienced severe neglect such that they needed to be hospitalized for treatment or for safety. As Lisa mentioned, children experiencing psychiatric or behavioral health issues that were so severe that they required treatment and stabilization at the Children's Hospital before receiving psychiatric services. In October and November of last year, I attended the trauma-informed care training of Andi and Dr. Clements, as well as the Train the Trainer training. And this was so valuable because it gave me knowledge, skills, language, and a framework to talk about, think about, and address the trauma and relationships between childhood trauma and health and behavioral health issues that I was seeing almost every day in my patients. Shortly before I participated in these trainings, our department was fortunate to receive a Building Strong Brains grant from the Department of Children's Services in Tennessee that allowed us to, over a 9-month period, do some training with staff at the ETSU Pediatric Clinic, get some training ourselves, and develop a process for screening for ACEs in our patients and in our patients' parents and caregivers. And so I'm going to share with you a little bit today about our experience with that screening, and then also talk about future directions. So we know from research what trauma can look like in children and adolescents in terms of behavioral health issues. It may manifest as avoidant behaviors, being disconnected in class or with one's peers, having outbursts, being angry and misbehaving, being hypervigilant or fearful. So we're trained to think about what has happened to that child who is exhibiting those behaviors. I want to mention a couple of recent research studies that were published this year. The first one is in BMC Pediatrics, and this was a systematic review of about 40 longitudinal studies that looked at the relationship between childhood trauma and not behavioral health outcomes, but biological health issues. So things like asthma. And what these researchers found is that there was fairly consistent evidence that childhood adversity and trauma is associated for increased risk of cognitive delays or developmental delays, asthma and asthma severity, sleep disruptions, obesity, issues with growth and physical development and maturation, more commonly to have infections or just somatic complaints, things like headaches, stomach aches, sort of those non-specific complaints at a higher level. These studies also looked, and these were in infants and toddlers and early childhood through sort of middle adolescence, that there were associations between adversity or trauma and changes in your cortisol level. So that's one of your stress hormones that is helpful in stressful situations, but when you're constantly exposed to stress can actually not be as helpful. Also changes in the immune system, nervous system, and epigenetic changes. What are those? Those are not changes in our genes, right? We get our genetic makeup from our parents, but actually changes that can occur in how genes are expressed, that can occur from things that you're exposed to in your environment, in your life, and that can actually manifest intergenerationally. So that was a very recent review that kind of strengthens the evidence between the link with adverse experiences and all of those issues, medical issues in childhood. That tells me as a pediatrician that if I have a child with severe asthma getting hospitalized all the time, or maybe a child with developmental delay or obesity, I need to think about what has happened to that child that could be contributing to those medical conditions. This other study was published in Child Abuse and Neglect in 2018, and it looked at the efficacy or effectiveness of interventions that could improve the biological effects of childhood adversity. So they reviewed about 35 randomized controlled trials. And again, these were looking at potentially beneficial interventions in children. These were things like working with parents around parenting, increasing parenting support and bonding, working with children around building self-esteem and goal setting and resilience, building resilience. And you know, as previous speakers have mentioned, we have a lot of work to do in terms of building the body of evidence for what are the effective interventions. But this was a good review that did show that these interventions, and they looked at 4 main types of interventions in children in different settings, institutional settings, community settings, and foster care, and did see that these interventions can improve things like cortisol levels, brain development, epigenetic regulation, inflammatory profiles, catch-up growth, and that the earlier we intervene and try to support positive parenting, and the more that we engage with families, the better the outcomes. So Dr. Nadine Burke-Harris was one of the co-authors of the studies that I just mentioned. She's also the author of a book called The Deepest Well, which is a really interesting, it's a good read, talks about evidence, stories, possible approaches to addressing this issue. I mentioned Dr. Nadine Burke because she and I actually worked together when I practiced in California many years ago. But we have also, in our clinic, adapted one of the screeners that she developed called the ACE-Q to screen for ACEs in our patients. And I'll share with you a little bit about that next. Just checking how I'm doing on time. Okay. So ETSU Pediatrics is a training clinic. So we have medical students from Quillen. We have pediatric residents that practice there. And we know that our patients are experiencing trauma and adverse experiences, and we know that our parents and caregivers of our children have been in the same situation. And so over the years, and this was partly in response to the epidemic of prescription drug abuse that we've talked about, and the many babies that come into our practice having been drug exposed, and who we know are living in families that are struggling with drug use. So we built at ETSU what's called an integrated care team. So this is systematic coordination of general and behavioral health care. So this means that I, as a pediatrician, and my nurse, we practice side by side with a clinical psychologist and a social worker, who we actually call in practice a behavioral health consultant, and a resource team member, to care for patients. And they help us at the time of a patient's well-child visit address resource needs and behavioral health needs in a very coordinated and integrated way. So we actually have been screening for some ACEs in our clinic for at least 7 or 8 years. We started out with developing a protocol for screening for postpartum depression in our mothers of our patients in the first 6 months of life. We as pediatricians were fairly terrified about doing this because we take care of kids, not adults. But this was something that was recommended by the American Academy of Pediatrics. We did it, and what we found is that we have a lot of mothers experiencing symptoms of postpartum depression, but also that mothers were very thankful and appreciative that we were asking about these symptoms, and that you did feel like it was the role of a pediatrician. After that, a few years later, we started screening for social determinants of health. So we used a screener adapted from a national screener called We Care that asked questions about whether or not families were running out of money to pay for food or housing or utilities by the end of the month, if they were having issues with transportation, if there were issues with violence in the home or drug abuse, if they had trouble with reading or understanding English. And with our resource team, That, by the way, our behavioral health and resource team also includes learners or interns from those different disciplines at ETSU, so they help us to provide services but are also being trained in this environment. We are able to help connect families to resource needs, and we know that that can help improve our patients' health outcomes. So over time, we have also created opportunities for building resilience for our patients. And I didn't know it while we were doing this, that we were actually putting in place programs that could enhance serve and return and brain development and help build resilience in our children and our families, because that's language I've more recently learned at Becky and Andy's training. But for instance, we have a reach out and read program. So we give out books and talk to and model to parents, how do you share a book with a young child? How do you take that special time during your busy day to do that? We also have a program called Read and Play for a Bright Future. We've developed tools and little books, that baby book that you might be able to see there if you're on the front row, that we use with patients in our practice to help really just engage with them and build trust and help to communicate with them about raising healthy babies. We also partner with Niswonger Children's Hospital and a lot of organizations in the community to conduct support groups and free Healthy Active Family events. Again, opportunities for engaging with families and building resilience. So what about our new ACEs screening program? So we used a screener that asked about, and this was with parents and caregivers, as well as about children, and this was for children 5 years of age and younger. So we had one screener for parents and one screener to complete about their child. And we ask about abuse, neglect, and household dysfunction. And we ask parents to simply report a total score, 0 to 10, the number of ACEs that were experienced. How did this help us? Well, for instance, little Abby Rose. It's an example of a 1-month-old with poor weight gain. Mom took buprenorphine or Subutex during pregnancy for management of opioid dependence. My training tells me I've got to figure out, does Abby Rose have any medical issues affecting her growth? I've got to figure out how to get Abby Rose more calories so she can grow. But these screenings that we have built into our clinic really enhance my perspective about what might be contributing to her poor weight gain. So for instance, screening with mom indicated several unmet social needs, lack of transportation, money for food, housing, utilities, and possible postpartum depression. And with our new ACEs screener, we were able to pretty efficiently identify that mom had an ACE score of 9. So she's coming into this role of being a new parent with that experience as a child, all those adverse experiences as a child, and how does that impact you as a parent? The case of James, a 5-year-old with persistent asthma who's been in the custody of grandmother for the past 2 years due to domestic violence in the home, coming to clinic with mom for the first time today. He's going to be repeating kindergarten this year. I shared with you evidence that ACEs can contribute to asthma development and severity of asthma later in childhood. That could be a factor. Father was incarcerated for robbery. We looked, this child's ACE score, it was 4, talking to mom more. She grew up in foster care herself due to a history of neglect and had an ACE score of 6. So again, this information just quickly and effectively enriches our perspective on how to help and serve patients. We have developed a couple of brief information handouts that we give to families when we do the screening about what are ACEs and how do you build resilience in your families. And I'm happy to share those with you if anybody would like copies. What did we find with our screening results? So in our clinic, and these are kids 5 years of age and younger, among parents and caregivers, 53% had an ACE score of 2 or higher, and 37.5% had an ACE score of 4 or higher. Among children, 9.1% had an ACE score of 2 or higher, and 3% had an ACE score of 4 or higher. So this data definitely suggests a need for continued screening and intervention and building interventions to help families. One thing that we found helpful in talking about the ACE score with families was the question, particularly with parents, how is what has happened to you affecting you and your family now? That was useful to kind of guide the approach to discussion about ACEs. But particularly with parents, these traumatic experiences have already occurred, and they really just seemed appreciative that we were asking about them. With our grant, we were able to build in some additional resources and partnerships in the community to help with parenting support and connecting families to resources who had a high ACE score. And that's something that we hope to do more in the future. One of my colleagues is a board-certified child abuse pediatrician, Dr. Deborah Mills, and I asked her back when I was a hospitalist one day, how do we prevent all this child abuse? And her response was, you have to build a community of people who are looking out for children. And I feel like that is something that we're doing here today with the trauma-informed system of care. And I'm excited to see what new things happen at ETSU and Niswonger, and really work more with the community organizations and agencies here today to help address ACEs in our children and families. Thank you.
Hi. So my name is Strickland. I am the manager of the St. Jude Clinic. So we do have a St. Jude Clinic inside Niswonger Children's Hospital. We're one of 8 in the United States, and we are really, really fortunate to have it. So one of the things with running a pediatric oncology clinic is we cause trauma to families. Telling you your child has cancer is traumatic. But we have found that a lot of our families come in with lots of background, lots of baggage, lots of issues. So I have been with St. Jude for about 14 years, and my aha moment was, and I've known Becky that long, we've kind of muddled through the beginning of our careers together, and meeting with her and realizing that just having a social worker in our clinic wasn't enough for these families. And that was fantastic, and ours is amazing, but it's not enough. So I went ahead and did the regular trauma-informed class, and then I decided to do the train-the-trainer. And actually I go to the bi-monthly meetings now, which keeps me refreshed and knowing what I'm doing. So I took it to my team at the clinic, and we have such limited time and such limited resources that to take it to your team and giving them all 4 hours at once is not reasonable. You can't do that. So I have decided every team meeting, which we have every week, I would just do small doses of it. So I did start with the removed video, which if you have seen it, it gives you all the feels, right? You feel everything you could ever imagine in watching that video. And that was perfect for my nurses, my front desk, everyone to watch, because it reminded us that the difficult patients, right, the ones that are always late, the one whose father's really angry, there's something else there, so just being a little kinder, coming up with just some small ideas. But I wanted my staff to come up with those ideas, give me the smallest thing. So it came from, we did so many different things, but one, just making sure we have enough tissues in the room. So we normally just keep a box by the door, but if we're giving you news, even if it's just having to give your child another shot, you're gonna cry, and to have to get up and go find the tissues is terrible. So making sure we have tissues all throughout the room is helpful. So there's not that embarrassing moment. So then we did some bigger things with pain protocols. So throughout our whole clinic, and now throughout Niswonger, we work with Child Life. And every single child, every single time that comes through our clinic, even if it's just a finger poke, we'll get numbing cream. And it takes 20 minutes for it to numb, which, for nurses, it's normally like, let's get these kids in and out. They're just here for lab work. But we had to stop that. It's traumatic. Every single poke is traumatic. So now we offer numbing cream, and it's 100%. I did lots of data on it. So those are some of the ideas we came up with. So within Niswonger, we did realize we needed trauma care for our caregivers. We do have deaths in our hospital, unfortunately, and we forget about the team that's taking care of these kids. So super fast, I will tell you, we are doing a couple different things. We're working with the chaplains. It's called Tea for the Soul. There's literally tea, and it is just time for staff members can come and go into a room and just breathe and get a hand massage and drink some tea and just relax a little bit. And then the other one with the Child Life is we've started a bead program where you, as the caregiver, anybody that was involved in this child's care, can choose a bead, and that strand of beads and a card will go to the family to say, we thought about you. I picked this bead because your child made me think of yellow, whatever it is. But that goes to the family, but it's healing for the caregivers. So all the trauma-informed, all of those little things are coming out of this training, and Lisa being on board and allowing our hospital to do this, and it's amazing, and we're so grateful for it. So thank you for being here. I'm glad you started.
Thank you, ladies. See, and Andi and I did not tell anybody what to do with it. They just heard the training and got the trauma-informed lens, and off they went. All right, our next group is going to be Family Justice Centers from Sullivan County, Karen Boyd and Heather Brack from Washington County, Johnson City, and Robin Crumley from our Boys and Girls Club. And when these three ladies finish up, we are going to take another 20-minute break and a networking opportunity. And then we're going to come back and hear from our last group, public schools, police, Safe Families, and then hear from Ms. Haslam and Mary Rolando about becoming a trauma-informed state. So unless you have to catch a plane, don't leave, and we'll hear from these ladies.
Good afternoon, everyone. Thank you for all being here. I am Heather Brack. I am the director of the Johnson City, Washington County Family Justice Center. And I do not have a slideshow, unfortunately. Sullivan County is much better at slideshows than I am, but she was kind enough to include a picture of my building that I get an opportunity to talk about. So briefly, I think everyone is coming up here, and what I've been enjoying is the aha moments for everyone. And my aha moment started very early. Becky Haas was actually on my interview panel for my position when it was created. She helped write the grant that formed the Family Justice Center here in Washington County. So from the very beginning, I've been on board and a part of or watching a piece of Becky's transformation of trauma-informed care inside of Johnson City. And it's kind of a blessing to have been able to approach the task of creating a Family Justice Center along with this trauma-informed care concept that Becky was bringing inside of this community. So I can't thank her enough for that. And one of the other things that she was able to do is guide me through the understanding that Johnson City as a community came together really well as practitioners to be able to bring together a community that is willing to grow and build together. And inside of that, we're exceptionally grateful to be able to have presentations and things such as this. And one of the things that I wanted to talk about just ever so briefly with trauma-informed care is, and I think somebody mentioned it earlier today, when you start talking about trauma-informed care and you go through the trainings and you do everything else like that, and it's a roadmap but not a prescription, and I think Dr. Clements said that almost exactly. And everyone always goes, well, what does that mean for your organization? And for us, the way I'm able to describe that is basically, how do you go from the training to that desk on that bicycle that somebody talked about earlier today? And it's different for everyone. And at our Family Justice Center, what does being trauma-informed actually mean for us? And for our clients, they come to us seeking services. So they're not seeking us out because they know that we are trauma-informed. They don't really necessarily know what that means even. But the one thing that they can absolutely tell you is every single one of their interactions that they've had previously, that we're not trauma-informed. And that's what they're bringing to you. And so I think that's one of the really important things about being trauma-informed, is understanding that they don't have to know that you're trauma-informed. They're gonna learn that from you. And you don't even have to tell them that that's why you're doing it the way that you're doing it. It's easy to say that everything that we do at Family Justice Centers is trauma-informed, but we don't have to tell our clients that. At the end of our interactions, they're telling us that. They're telling us that they feel the difference in the way that they're being responded to, that they're being listened to. They will tell us that, where was this when I needed this 2 years ago or 5 years ago, or why doesn't everyone respond to me like this? And I think that's the brilliance of being trauma-informed, and that's the wonderfulness of what a Family Justice Center is able to bring to our clients. And so what that means for clients, for us, is things like how we decorate our buildings, the things that we're able to provide, the way we train our staff. One of the things that I do with trauma-informed care is we make sure that what we do for our clients, we do for our staff. It's taking care of it's helping the helpers, so to speak. And there is no line that's drawn between those interventions that we provide for our clients and those ones that we provide internally. There's coloring pages in every client room, there's coloring pages in everybody's office as well. We debrief after every hard interaction, and oftentimes that also includes a therapy bunny somewhere in somebody's arms. We do these things because they are the trauma-informed way of approaching every policy and interaction that we do as an organization. And really, that's what I wanted to bring about what trauma-informed is there's no one way to tell you how trauma-informed your organization is able to be. It's everything that you are, and the best construct of what that looks like at the end of the day is when somebody else comes and tells you that they know what wasn't and why they're so appreciative of what you're able to bring to them. I believe Karen is up next to tell you about what she's able to do as well.
This is our Family Justice Center in Sullivan County. So we're fortunate, we actually have a neighboring Family Justice Center right here in Johnson City, and both of the Family Justice Centers in this area were actually sponsored under an initiative that started by Governor Haslam several years ago, and has been funded through the Office of Criminal Justice Programs to help with the safety of families and children in communities. So very briefly, for those of you that aren't aware what a Family Justice Center is, a Family Justice Center is one safe place that victims of interpersonal violence can come and access any service they need to move away from that life of fear and violence and towards a life of safety and freedom. Right? That sounds very trauma-informed, doesn't it? And I think this program actually started before trauma-informed was really a big thing. So the idea is now a rape victim or a domestic violence victim can come one place, and instead of having to drive to the courthouse and to the police department and to the hospital, they can come into one place that's made to make them feel comfortable and access all their services. So just from a trauma-informed care perspective, now that I've started learning about it, I'm going to roll through these real quick. I think one of the first things any agency can do is to make yourself as easily accessible as possible. Right? That's the whole point of our Family Justice Center, is come one place and get anything you need. So whatever service it is you're providing or whatever it is you're doing for someone, make it as easy for them to get that from you as it possibly can be. The second thing, and Heather talked about the decor and how we set up the inside of our Family Justice Centers, is really pay attention to what this person is going to see and hear and feel when they're with you, because things like that become very important. And of course, Heather and I don't have the luxury of having people come into our center for help that aren't in trauma, right? Every single person that we come into contact with is actively in trauma at the time. And some of you all will have people, like as advisors in college, you'll sometimes have people who aren't there suffering from trauma. But when you do have people in who have these ACEs and who have experienced trauma, it's important to remember the physical stuff that's around you. And I'm going to skip on down here. I've been to all of Becky and Dr. Clements' presentations, and one of my favorite things is when they talk, and they'll talk about a specific person that they helped or that they interacted with, and at the end of that interaction, when they've been trauma-informed, that person will look at them and say, "You made me feel human. This makes me feel human." And we hear that a lot at our Family Justice Center. And y'all, it breaks my heart every single time, because you know what I think? You are human. Like, we are human. And I think a really great part of trauma-informed and being trauma-informed is that you're building on that common sense of humanity. And some of the things that we do at the Family Justice Center, and Heather does at hers, seem really small, but that's when you hear it made me feel human. We've actually partnered with ETSU and Valid Health in Sullivan County to try to get nurses trained as sexual assault nurse examiners. Because as we opened, we realized our victims don't have access to that. There's not a sexual assault nurse examiner in all of Sullivan County. And so I was able to find my people out there who were concerned about that as well. We pulled together, and in December of 2017, we had 0 sexual assault nurse examiners that served this area. And today we have 15. So one of the things that we've done with that is we collect items. One of our volunteers who put together these hope and healing bags. So they're backpacks that have a new outfit in it. It's got underwear and a bra and shower stuff and a towel, because we realized that as victims went to the hospital for rape kits, they were sent home many times with no shoes on in a hospital gown, because the nurses had to collect those items of clothing for evidence. And so that's one of the things that sort of came from us sitting down at the table and talking. We're a nonprofit. All of you out there who are nonprofits, you know the hardest thing in the world is to get money. Nobody wants to give you money, but do you know what everybody does want to give you? A pair of socks to put in that backpack. They want to give you stuff that they know is going to go to someone in a state of trauma and that's going to help them. I went on several calls and was actually at the hospital when some of our clients received care from these Valley Health trained nurses, and I was able to give them these backpacks that had been donated. And every time there was something in that backpack that just really touched that person. We were on one call with a human trafficking victim who'd been separated from her family for a number of months. She was a human trafficking victim. And she pulled the comb out of that backpack, and she just sat there combing her hair and talking about how it was the best thing she'd ever had. And y'all, it was one of the combs from the, 50 combs come in the plastic bag, that's what it was. But it meant so much to her, and she said it made me feel human again. So y'all are here because you share in that common sense of humanity. There's so much stuff you can do. There are lots of resources. Email me. Thank you for your work. And, lots of little things really add up to make a big difference.
Hi, my name is Crumley, and I've been the paid director for the local Boys and Girls Club for 7 years. But I've also worked with the organization as a volunteer for over 30 years. I think it, sorry. For those that don't know, we're a year-round organization that helps school-age children to realize their full potential as productive, responsible, and caring adults. And this includes tutoring and mentoring opportunities, as well as activities for fun learning in our 8 program areas. As you've seen from all of our previous presenters and your own communities, we are here today because the need is great. The makeup of our families is constantly changing. And this changes not only who is raising our kids, aunts, uncles, grandparents, foster parents, etc., but it's also why other people are raising our kids. The opioid crisis we've talked about, poor decisions that lead parents to jail or death, behavioral issues in our kids and our caregivers, and toxic stress are just a few of the contributing factors for our ever-changing family dynamics. I ran across this quote from Elizabeth Fuller. It says, "Never reach out your hand unless you're willing to extend an arm." And I love the visual that it gives us in life. When you extend your hand to a person, you are connecting. When you extend your arm, you are committing. When trauma enters our life, many of us need that stabilizing force to help us recenter, regroup, and gain strength from each other when life throws us off balance. And many times, as we've talked today, it's about building relationships and showing through our actions that we truly care. Helping those is to educate ourselves. We've talked about that. Step 1, education is a never-ending process. Keeping up with new ways to do things is a lifelong process. So we participated in the SAMHSA community involvement presentation at ETSU in 2015. We hosted and participated in the 4-hour TIC training session with Becky and Dr. Andi at our site for several regional Boys and Girls Clubs in 2016. And in August 2016, we enabled Becky Haas to go to represent us at the all-staff training where participants were in Knoxville. These are the frontline youth development professionals from across the state of Tennessee for Boys and Girls Clubs across Tennessee. And that gave them a chance to engage in training and network opportunities to help them do a better job for our kids. We now include as part of our routine staff training a 2-hour TIC training. You can adapt those PowerPoints for the time that we are given. We do that twice a year in May and August before our summer and after-school programs start. And we also utilize parts of these trainings for our parents and our volunteers throughout the year. We belong to our area's TIC system of care group, where we stay encouraged and engaged with the community that we serve. It's always good to have a time to share ideas and takeaways that we can bring back to our respective groups, and we are never too old to learn something new. And step 2 is developing an ongoing culture of change. You know, in 2016, our Boys and Girls Club collaborated with Dr. Andi from ETSU and Becky from the Johnson City Police Department in a Building Strong Brains and Strong Families grant. This allowed ETSU to hire a trained facilitator to work with our team to develop and conduct the trauma-informed care trainings at all levels, and to start parent-guardian trainings and observations for research efforts. Also with this grant initiative, we built a calming room early in 2017 with the desire to provide a place where kids, staff, volunteers, and parents could find a safe, quiet place to de-escalate from overstimulation, anger, or any other feeling they were experiencing. We named the room the Treehouse earlier this year when I asked some kids using the room quite frequently what places in their experiences or thoughts gave them a sense of safety or security, and that's where the Treehouse name emerged. It's important to note here that you can create a safe space anywhere. One of our rooms, the Art Center, is a large room, and our youth development professional who runs that area created her own safe space. It's inclusive of the environment she works in, it's comfortable, and it gives kids a place to de-escalate and have a voice. This is a true example of creating a culture of change. Another activity we do is our daily staff roundup. We use this time for staff to connect and focus on sharing any concerns about our kids or families that we may or may not know is happening. This is where we share as a team the rest of the story, with staff who may not have all the facts or who may have prejudged a kid's behavior. We allow staff to have a voice, we listen to their concerns, and we share potential solutions with each other. One area we're currently working on, and several of us talked about it, is our policies and procedures. The need is growing to go beyond just training, and we are constantly looking for ways to be advocates to the families we serve and not to re-traumatize our kids in the process. We added a text alert system to stay connected to caregivers and provide them with timely information as needed to reduce their stress. We're reviewing our membership forms for language that might be unintentionally re-traumatizing, and we continue to make our front programming areas warm and friendly. Community outreach, besides being a contributing partner in our local TIC system of care, we work with many local agencies to help with feeding, counseling, and caring for the families we serve. We are constantly engaging with higher education partners like East Tennessee State University to provide opportunities for us to go deeper. We have 2 interns who just started this semester. One is here, I won't point her out. And they are helping us to enhance our trauma-informed care initiatives with an emphasis on finding those training modulars to help staff and volunteers in situational learning. Also developing a club safety committee to include parents, teachers, and staff. They're also charged with researching best practices in child serving agencies. Who is doing what well, and how can we get better as a club by utilizing some of those concepts and adding them to our policies and procedures? Also, I highly recommend you look around your communities and outreach to bring talent onto your board of directors. People like Becky Haas who can help encourage policy changes at your site. Our next desire moving forward to the next level of care is to have some sort of on-site counseling partnerships available for the families we serve. I talked about our TIC room. Here are some photos of our treehouse. And as I said earlier, you can take any space. This one's only about 8 foot by 10 foot and make it your own. At the club, we're all about making good choices. So we chose to post the saying, "You are not what has happened to you, you are what you choose to become." Through the years, we've always made space to have conversations with kids and adults, whether it's been in your office or just sharing some space on the floor together with a child. It's hard to believe our TIC room has become a way of life at the club. Some of the leadership at the club, I asked them to just share some comments, and here's a few of them. This is from Miss Lauren. The TIC room is one of my favorite rooms in the club. It's a room that can be used in any scenario. We can dim the lights, have access to beanbags and tactile toys for any situation. The members feel safe in our treehouse, from Miss Lauren. Mr. Anthony says, peace and serenity. The TIC room is the foundation of these qualities to our children who need it the most. Named the treehouse, it is a second home for most children and a safe place. A place where they can let down their guards, cry, scream, and more if they need a room to do it. Without this room, the Boys and Girls Club would be incomplete. And boy, if you've not witnessed that, that is a true statement. And then the last one, we see so much happening in the lives of our kids every day. Our TIC room and ongoing whole health efforts provide us with one more vital tool to make a difference in the lives of the children and the families we serve. The rewards we reap in helping to be a part of changing behaviors and lives is beyond words. And in closing, as you've seen from each presenter so far, caring and reaching out to those we serve is important. Everyone has a story to tell. Trauma looks different in every situation. Everyone is unique. I asked the staff recently to take some small group photos of our kids. And for this presentation, I randomly chose 3 of those photos to put in the last slide. And in preparing the notes for today, I viewed the kids shown in these photos. Sorry. And this is what we have represented in just 24 kids. 2 foster families with parents in and out of jail. A 5-person family, recently homeless and just moved into government housing. Single parent family with mom working to become a pharmacist. An immigrant family whose dad was deported, but the kids were born in the United States. Grandparents raising their grandson. 1 member from another country. Many members are in counseling at school and outside of school. 1 member's 12-year-old brother was just currently moved to a youth facility in another state. Only 1 child's family in this group of kids represented is being raised by both original parents. So, don't ever underestimate the impact you have on the choices being made in the lives that you serve. Whether that is a one-day touch on a life, or many days over many years. Our club chooses to be a conduit to help heal the long-term effects of childhood adversity and help to build resiliency in those we serve, with the ultimate goal to have healthier kids and families in our community. In the words of Ronald Reagan, we can't help everyone, but everyone can help someone. If we can do it with little to no budget, you can do it. You've made the choice to be here today for a variety of reasons. As you can see, our community chooses to make a difference, and we are more than willing to help your community do the same. Thank you.